Welcome back to the Deep Dive. Today, we are focusing on achieving, well, true professional mastery. What is arguably the most vulnerable and critical time in a patient's surgical timeline. We're talking about the immediate hours right after the procedure is finished.
Yeah.
We are stepping deep inside the Postanesthesia Care Unit, or PCU.
And this unit is, it's the ultimate high-stakes environment. It's really not just a recovery room. It's where patients transition from an artificially stable state, maintained by sophisticated anesthetic agents, back to full physiologic self-sufficiency.
Right.
And this requires intense, critical, and continuous assessment focused on preventing complications and intervening rapidly.
Our sources draw a very clear boundary here, don't they? The entire timeline is called the Pre-Anesthesia Patient Care Continuum that covers pre-anesthesia, intra-op, and post-op.
The whole journey.
But our deep dive today focuses strictly on post-anesthesia recovery. So the stabilization activities, the protocols to minimize adverse events, and the standardized assessment needed to safely move the patient forward.
Exactly. And for you, the listener, our mission today is to move beyond just familiarity with these concepts to, well, true mastery.
Okay.
This means understanding not just the assessment tools like scoring systems, but also their inherent limitations.
That's key.
And not just knowing the complications, but really grasping the intricate physiological mechanisms that drive them. And critically, mastering the standardized communication that ensures continuity of care. It's about the whole picture.
Let's start then with those non-negotiable initial moments. The source material is absolutely adamant about this.
What is?
The immediate priorities in the PCU, those very first few minutes, are always focused entirely on evaluating respiratory adequacy and circulatory adequacy.
Non-negotiable.
Any sign of compromise in these two areas demands immediate correction. No delays. Okay, so let's unpack how this hypervigilance even begins. It actually starts before the patient even leaves the operating room, right? With mandatory preparation.
That's exactly right. Before that transfer happens, PACU personnel must be notified. They need to know the expected transfer time and, crucially, the patient's acuity level.
And this isn't just, being polite.
No, it's vital preparation time. The staff has to ensure that necessary specialized equipment is ready and waiting.
Like what kind of equipment?
Well, it could be anything from a mechanical ventilator, a capnograph for monitoring CO2, maybe a nebulizer for breathing treatments, or the setup for invasive monitoring like an arterial line.
Got it.
And this advance notice is also crucial for assigning the patient to a practitioner who has the appropriate experience for the complexity of that specific case. You want the right eyes on the right patient.
So the moment the patient actually rolls through the door, it's a required collaborative effort.
Absolutely.
The anesthesia provider, the PCU nurse, maybe the OR nurse if they're available, they all have to converge for that initial stabilization. What's happening in that first, say, 60 seconds?
Well, the absolute first priority is to initiate continuous monitoring immediately. No delay. That means getting the ECG on for cardiac rate and rhythm, getting a prompt blood pressure measurement, assessing organ perfusion adequacy, checking skin color, temperature, mental status, and initiating any necessary invasive monitoring, like that arterial line we mentioned.
And the whole team is looking for.
They're aggressively looking for any signs of inadequate oxygenation, ventilation, or cardiocirculatory compromise right there at the bedside. It's rapid assessment.
And the anesthesia provider's role doesn't just stop at the door. Their responsibility is absolute during this transfer.
Completely. They have to remain active assisting with oxygen therapy if needed, verifying that the airway is secure and adequate, and assessing the circulatory status. Their active presence is really the bridge to a smooth transition of care.
And this presence, it's actually regulated by professional standards, isn't it?
It is. The American Society of Anesthesiologists, the ASA, they mandate that a member of the anesthesia care team must remain physically present in the PACU until the PACU nurse formally accepts responsibility for the patient's nursing care.
And that acceptance only happens when certain conditions are met.
Exactly. Only after the patient's airway status, their ventilation, and their hemodynamics are all deemed appropriate. It's a literal, formal handover, like a contract of safety, as you said.
That handshake, that transition, it's all built around the anesthesia report or the handoff.
Right.
And this seems to be a point where patient safety can either succeed or potentially fall apart. The sources really highlight some significant failure points here.
It's quite astonishing, actually. The sources consistently list reasons why this critical process is frequently compromised.
Such as?
Things like a lack of standardization across institutions, inadequate preparation by either the giver or receiver of the report, poor communication skills, actual information loss during the transfer, and perhaps the most insidious one, distractions and interruptions during that critical exchange.
Yeah, I could see how that would be a huge problem.
When you're dealing with minute-to-minute physiological stability, losing even one piece of key information is a massive patient risk.
So how do we mitigate those risks? The solution presented seems to be standardization. Thinking of this less like a casual chat and more like, say, a flight crew going through a checklist before takeoff.
Precisely. That's a great analogy. Standardized, logical communication and the mandatory use of checklists, like the one detailed in box 55.3 of the source material, are strongly recommended to minimize omissions and errors.
And the report itself needs to be comprehensive. What does that include?
It has to cover the patient's preoperative history, key intraoperative management details, like the specific anesthetic agents used, the timing and dose of the last opioid given, the estimated blood loss or EBL, and the total fluids administered.
Also, any unexpected events during surgery.
Definitely. Any deviations from the expected course, and crucially, the specific PCU treatment plan needs to be outlined, including any anticipated problems or things to watch out for.
And the American Association of Nurse Anesthetists, the ANA, they add another layer to this.
Yes, they emphasize that this must be a two-way, preferably face-to-face interaction.
So not just a monologue.
Absolutely not. It's not a data dump. The receiving PCU nurse must have the opportunity to ask clarifying questions, verify details, and ensure that the treatment plan is crystal clear before they accept responsibility.
Okay, so once that meticulous handoff is finally complete, the PCU nurse then begins their detailed admission assessment.
Right. And the goals here are really comprehensive.
What are they trying to achieve?
They need to establish the patient's immediate physiologic status, set a baseline so they can track trends over time, assess the surgical site itself, checking for bleeding, swelling, drain function note, any residual effects from the anesthesia, and basically compile all the data needed for eventual transfer or discharge decisions.
And this detailed baseline, it requires objective measurement, right? You can't just eyeball it.
No, definitely not. The standard clinical approach is to combine a scoring system with a full head-to-toe body systems assessment.
And what's the most common scoring tool used in the PACU?
That would almost certainly be the Aldrete post-anesthetic scoring system. It's widely used.
How does it work?
It simplifies a complex recovery state into 5 key variables. Activity, can they move extremities? Respiration, effort and depth. Circulation, blood pressure compared to baseline, neurologic status, level of consciousness, and oxygen saturation.
And each gets a score?
Yes. Each variable is scored 0, 1, or 2. A higher total score generally suggests better physiological stability at that moment.
But here's a really critical insight from the source material, something that moves us toward that mastery level we're talking about. While the Aldrete score is kind of the gold standard for that initial admission snapshot, for measuring immediate stability.
Yes.
Its predictive value for determining overall recovery, for saying this patient is ready for the next step, hasn't actually been prospectively studied.
That's a hugely important point.
So relying solely on that score to predict future safety could be risky.
Absolutely. The score tells you where the patient is right now at this specific point in time, but it doesn't necessarily predict their trajectory or guarantee they'll stay stable. And that's why organizations like ASPAN, the American Society of Perianesthesia Nurses, they don't actually mandate using a specific scoring system.
Oh, interesting.
Yeah, they recognize its utility, but only as one component within broader facility discharge criteria. They strongly emphasize that clinical judgment based on continuous assessment must always govern the final decision.
So the score is a tool, not the whole answer.
Exactly. The assessment has to be ongoing, covering everything from the patient's temperature and their cardiac monitoring strip to the integrity of their dressings, the function of their drainage tubes, their pain level. Everything is continuous vigilance.
Okay, let's dive into the core of that continuous PACU assessment. Respiratory function is constantly monitored for 3 major risks: obstruction, hypoxemia, and hypercarbia. Let's start with airway obstruction, which the sources say is the most common immediate issue.
It is. And the causes are, well, they're simple but profound. It's primarily the loss of pharyngeal muscle tone.
Why does that happen?
It's due to the lingering effects of anesthetic agents any residual neuromuscular blockers that haven't been fully reversed, and also opioids, which can relax those muscles.
Yeah.
When those upper airway muscles relax, gravity simply takes over.
And the primary mechanical culprit, the thing actually blocking the airway, is often just the patient's own tongue falling back against the posterior pharynx. It sounds almost deceptively simple, doesn't it?
It does, but it's incredibly common and potentially dangerous. The signs are often acoustic first. You might hear snoring or gurgling sounds.
Or physical signs.
Yes, or you'll see physical signs like the use of accessory muscles in the neck and chest. You might see intercostal retractions between the ribs or suprasternal retractions above the collarbone as the patient strains to pull air past the blockage.
So how do you treat it? It seems like there's a clear progression.
There is. Treatment must follow a defined progression. You always start simple, with simple tactile stimulation, maybe a gentle tap on the cheek or a verbal command.
And if that doesn't work?
If that fails, you move to physical maneuvers. The jaw thrust, which lifts the tongue base forward, or the chin lift. Basic airway maneuvers.
If those manual maneuvers still aren't sufficient, the next step is often an artificial airway device.
Correct. And here's a fantastic clinical detail the sources point out. The nasal airway, or nasal trumpet, is generally preferred over the oral airway in a patient who is starting to emerge from anesthesia.
Why is that?
Because the nasal route is far less likely to trigger the patient's gag reflex or potentially induce vomiting, which is a major risk in a semi-conscious patient.
Makes sense.
Alternatively, you might use a combination of a jaw thrust maneuver along with continuous positive airway pressure, or CPAP, applied via a tight-fitting mask.
At what pressure?
Usually around 10 to 15 centimeters of water. That moderate positive pressure often acts like a pneumatic splint, helping to hold the upper airway open.
And if, despite all these steps, stimulation, maneuvers, artificial airway, CPAP, the obstruction still isn't relieved,
then the situation is critical, and the patient will likely require reintubation by the anesthesia provider to secure the airway definitively.
Okay, now let's pivot from that passive obstruction to a more active, reflexive, and frankly life-threatening closure laryngospasm.
Yes, laryngospasm is a severe involuntary spasm of the laryngeal muscles. It results in either partial or complete closure of the glottis, the opening between the vocal cords.
What does that look like clinically?
Well, if the closure is incomplete, you often hear that classic high-pitched crowing sound on inspiration, which is called stridor. If it's a complete spasm, you hear nothing.
The silence.
Silence, absent breath sounds, and the patient will rapidly desaturate, their oxygen levels plummeting. It can be triggered by almost any irritation in the airway blood, secretions, sometimes even just the withdrawal of the endotracheal tube itself can stimulate it.
This sounds like it demands immediate aggressive action.
It absolutely does. Treatment starts similarly to simple obstruction, a firm jaw thrust to open the airway manually, but it's combined with much higher levels of CPAP.
How high?
Sometimes up to 40 centimeters of water. It's a tremendous amount of pressure, really designed to physically force the vocal cords open against the spasm.
And if even that high-pressure CPAP is unsuccessful?
Then the anesthesia provider must intervene pharmacologically. This usually involves giving a small subparalytic dose of intravenous sacchinolcholine.
What does that do?
Sacchinolcholine is a rapid-acting muscle relaxant. It instantly breaks the spasm by paralyzing the laryngeal muscles. However,
There's a catch.
yes, there's a catch. It also paralyzes the diaphragm and other respiratory muscles, so it necessitates assisted ventilation, usually with a bag mask device, for the subsequent 5 to 10 minutes until the drug wears off.
So preventing laryngospasm seems key.
Absolutely. The elite professional knows that prevention here is paramount. Meticulous oropharyngeal suctioning before extubation to clear secretions is probably the single most important preventative step.
Moving to specific high-risk groups, patients with obstructive sleep apnea, or OSA, they're constantly fighting against this post-anesthetic muscle relaxation, aren't they?
That's exactly right. For patients with known or suspected OSA, that diminished upper airway muscle tone dramatically increases the risk of obstruction in the PCU.
And that leads to?
It's associated with increased PACU complications, longer PACU stays, and unfortunately, more frequent unplanned hospital admissions after what was supposed to be outpatient surgery.
So identifying these patients beforehand is critical.
Vital. Preoperative screening, often using standardized tools like the Stott-Bang clinical scale, is essential for flagging this risk proactively.
And the management for these patients in the PCU.
It's really comprehensive. It starts with a well-planned anesthetic, maybe favoring regional techniques with minimal sedation if possible. But postoperatively, the most important thing is ensuring the patient uses their home CPAP machine.
They need to bring it with them.
Yes, they absolutely must be encouraged to bring their own CPAP machine to the hospital or surgical center. Using it consistently in the PCU can make a huge difference.
Okay, let's shift focus now to hypoxemia. This is defined clinically as low arterial oxygen pressure, or PO2, specifically below 60 millimeters of mercury. Basically, the tissues aren't getting enough oxygen.
Correct. And the clinical signs, especially early on, can be surprisingly sneaky or vague.
Like what?
Early on, you might just see agitation or restlessness, but those symptoms can easily be mistaken for pain or emergence delirium or even anxiety.
So you need a high index of suspicion.
Very high. The late, more dangerous signs are things like bradycardia, a slow heart rate, and eventually unresponsiveness. Physiologically, there are 4 main reasons this happens in the PCU.
What are they?
First, hypoventilation, which means the patient isn't breathing enough, leading to a buildup of carbon dioxide or hypercarbia, which displaces oxygen. Second is diffusion limitation, where oxygen has trouble crossing the alveolar capillary membrane. Third is shunt, where blood passes through the lungs without picking up any oxygen at all, like in severe pneumonia or atelectasis.
And the fourth?
And the fourth, and most common cause in the PCU, is ventilation perfusion mismatch, or VQ mismatch. This means some areas of the lung are getting air but not enough blood flow, or vice versa.
It's also vital to remember the oxyhemoglobin dissociation curve when we're relying on monitoring, like pulse oximetry.
Absolutely crucial. Factors like changes in the patient's pH level, their core temperature, their PCO2 level, and a compound in red blood cells called 2,7,3-DTG, all of these can cause this curve to shift.
What does that mean, practically?
It means that the relationship between the oxygen saturation percentage, shown on the pulse oximeter, SpO2, and the actual amount of oxygen dissolved in the blood, PaO2, can change.
So a good saturation number doesn't always guarantee good oxygen delivery.
Exactly, especially if the patient also has low hemoglobin, for instance, from surgical bleeding. A high saturation percentage on severely anemic blood might not be delivering enough total oxygen to the tissues. You have to interpret SpO2 in context.
Okay, focusing on specific causes of hypoxemia in the PCU, the sources state that atelectasis is the single most common cause of postoperative arterial hypoxemia.
That's correct. Atelectasis is the partial collapse of lung tissue, usually alveoli. It's typically caused either by decreased lung volumes, shallow breathing due to pain, for example, or by bronchial obstruction, perhaps from secretions.
And the treatment seems pretty foundational.
It is. It starts with providing humidified supplemental oxygen. Then you need to encourage aggressive lung expansion maneuvers, coughing, deep breathing exercises, and using an incentive spirometer.
Prevention seems key here, too.
Often more effective than rescue. Excellent pain control, allowing deeper breaths, and encouraging smoking cessation well before surgery can significantly reduce the risk of atelectasis developing in the first place.
Next up, a more dramatic cause, pulmonary edema. This is fluid actually flooding the alveoli, interfering directly with gas exchange. And it's split into 2 dramatically different types based on the cause.
Right. First, we have the more commonly understood type, cardiogenic pulmonary edema. This is caused by increased hydrostatic pressure in the pulmonary capillaries, usually due to fluid overload or left ventricular failure. The heart pump isn't handling the fluid volume effectively.
Okay, that makes sense. But the second type is the one often associated with a PCU crisis, isn't it?
Yes, that's non-cardiogenic pulmonary edema, also known as negative pressure pulmonary edema.
And this is where that severe upper airway obstruction we talked about, like laryngospasm, can become a secondary terrifying threat.
Exactly. When a patient tries to inhale forcefully against a completely closed or severely obstructed airway.
Like trying to suck through a blocked straw.
Precisely. They generate extremely negative pressure inside their chest cavity, inside the pleura. This intense negative pressure literally sucks fluid out of the pulmonary capillaries and into the interstitial space and alveoli.
It's a mechanical fluid shift caused by the obstruction itself.
Yes. And the sources specifically note that patients who are younger and more muscular are at higher risk because they are capable of generating greater negative inspiratory forces during an obstruction.
How do you treat pulmonary edema?
Treatment for both types involves, first and foremost, maintaining oxygenation. This often requires using CPAP, or positive end expiratory pressure, PEEP, to help keep the alveoli open and push fluid out. You also need to reduce the overall hydrostatic pressure, typically using diuretics like furosemide.
And for cardiogenic causes.
For cardiogenic edema, you might also use medications to reduce preload or afterload, like nitroglycerin or nitroprusside, to ease the strain on the heart.
Is there any good news with negative pressure pulmonary edema?
Yes, the good news is that the non-cardiogenic negative pressure type, once the underlying airway obstruction is definitively resolved, typically resolves relatively quickly, usually within 12 to 48 hours with supportive care.
Okay, we also must discuss pulmonary embolism, or PE, a potentially deadly complication.
Absolutely. And the risk profile for PE is classically summarized by the Virchow triad. Do you remember what that involves?
Let's see, venous stasis, hypercoagulability, and endothelial injury, or blood vessel wall abnormalities.
Exactly right. Venous stasis, slow blood flow, hypercoagulability, blood prone to clotting, and vessel wall injury. Surgery itself, especially major pelvic or long bone procedures, immobility, obesity, malignancy, and advanced age all accentuate this triad.
And where do most of these clots come from?
The vast majority, around 90%, originate as deep vein thromboses, DVTs, in the large veins of the legs.
Clinical suspicion for PE must be high in the PCU. What are the classic signs?
You're looking for the sudden acute onset of tachypnea, rapid breathing, dyspnea, shortness of breath, and tachycardia, rapid heart rate, often in a patient who is already receiving supplemental oxygen. Sometimes classic pleuritic chest pain occurs.
Tragically.
Tragically, sudden cardiovascular collapse and death is the first presenting symptom in about 25% of cases, so you may not get those warning signs.
How is it diagnosed definitively?
The standard now is multi-detector CT pulmonary angiography, CTPA, which has largely replaced older methods like VQ scanning.
And treatment.
Once PE is suspected or confirmed, treatment focuses immediately on correcting the hypoxemia, providing hemodynamic support if the patient is unstable, and starting anticoagulation therapy without delay.
What anticoagulant is preferred?
Intravenous heparin is generally the drug of choice initially, especially if there are concerns about renal function, as its effect can be easily monitored and reversed if necessary. The goal is to prevent fertile clot formation and propagation.
Okay, let's move to aspiration, another potentially devastating airway emergency. While aspiration of blood or foreign material is dangerous, the sources emphasize that aspiration of gastric contents is the most severe form.
Yes, because the acidic stomach contents cause an immediate chemical pneumonitis, a severe inflammation of the lung tissue.
What does that lead to?
This initial chemical injury often triggers diffuse bronchospasm, severe hypoxemia as gas exchange is impaired, widespread atelectasis, and can progress to full-blown acute respiratory distress syndrome, or ARDS.
Prevention seems paramount here.
Absolutely. Things like giving H2 blockers or prokinetic agents preoperatively to reduce gastric volume and acidity, and using rapid sequence induction techniques for intubation in high-risk patients are key preventative strategies.
And if aspiration does occur, what's the post-op treatment in the PCU?
It's strictly supportive care. That means providing supplemental oxygen, possibly using PEEP to help recruit collapsed alveoli, and a mechanical ventilation if respiratory failure develops.
What about antibiotics?
This is a crucial insight from the sources. Prophylactic antibiotic use right after aspiration is actually discouraged
Why is that?
because it hasn't been shown to improve outcomes and can actually encourage colonization by resistant organisms. Antibiotics are only indicated if the patient later develops clear signs of a bacterial infection like fever, purulent sputum, or changes on chest x-ray.
Got it. Supportive care first. We also need to cover bronchospasm briefly. This is an increase in bronchial smooth muscle tone, essentially an asthma attack in the PCU.
Right. It can be caused by underlying conditions like asthma or COPD, but it can also be triggered by extrinsic factors in the perioperative period,
Such as
aspiration, irritation from airway suctioning, trauma during intubation, or sometimes an allergic reaction causing histamine release.
the signs are usually audible wheezing and dyspnea. How is it treated?
First, you try to remove or treat the precipitating cause if possible. Then, pharmacotherapy is the mainstay. The gold standard treatment is inhaled beta-2 agonists, like albuterol, delivered via nebulizer or metered-dose inhaler.
And if that's not enough?
For severe refractory cases, the source material interestingly notes that certain potent inhalation anesthetics themselves, like sevoflurane, can actually be reintroduced in a controlled manner as a rescue therapy because they possess very strong bronchodilating properties. Steroids might also be used.
Okay, finally in this respiratory section, let's address hypoventilation. This is simply a decrease in respiratory rate or tidal volume, leading to an increase in arterial carbon dioxide levels, PaCO2. And it stems from two main issues, right?
Correct. Either there's a decrease in the central respiratory drive from the brainstem, or there's poor respiratory muscle function.
Central drive depression sounds like it's often related to the anesthetic itself.
Very common. It's usually due to the residual effects of inhaled anesthetics, intravenous agents like propofol, or especially opioids.
And there's a specific warning here for the elite professional.
Yes, an important point. An intravenous fentanyl dose administered right before the patient emerges from anesthesia might not actually reach its peak respiratory depressant effect until the patient is already in the PACU.
So they seem okay initially.
They might seem okay when stimulated during extubation, but then the removal of that stimulus combined with the peak opioid effect hitting can lead to a secondary, sometimes dangerous, stage of respiratory depression when they become less stimulated in the PACU.
And the second major cause of hypoventilation: poor muscle function.
Yes, and a key issue here is inadequate reversal of neuromuscular blockade, what we call residual paralysis.
The patient is still weak from the muscle relaxants used during surgery.
Exactly. And the sources detail how complex this can be. They note that factors like electrolyte imbalances, particularly hypokalemia, low potassium, profound hypothermia, metabolic acidosis, and even certain antibiotics like aminoglycosides can all inhibit the effectiveness of the reversal agents we use, like neostigmine.
Can you explain that mechanism a bit? How does something like hypokalemia interfere?
Well, for instance, normal potassium levels are crucial for proper function of the neuromuscular junction, where the nerve signal triggers muscle contraction. Hypokalemia can impair this transmission, making it harder for reversal drugs, which work by increasing acetylcholine at the junction to effectively restore full muscle strength. It's a multi-layered problem.
This really underscores why objective monitoring is so essential.
Absolutely critical, because pulse oximetry, while vital for monitoring oxygenation, SpO2, tells you absolutely nothing about the adequacy of ventilation, whether the patient is effectively clearing CO2.
So what should be used?
For any patient considered at risk for hypoventilation due to opioids, residual blockade, OSA, etc., continuous capnography, which measures the end-tidal CO2 concentration in expired breath, is vital. It gives you a direct, real-time indication of whether they are actually breathing effectively.
Okay, let's pivot now to the second pillar of immediate stability that we mentioned at the start, the cardiovascular system. We generally define hypotension as a drop of more than 20% below the patient's known baseline blood pressure.
Right, or sometimes defined by absolute numbers, like a systolic blood pressure, SDP, persistently below 90 millimeters of mercury, or a mean arterial pressure, MAP, below 60.
But the sources emphasize something important here.
Yes, they stress that while those numbers are important benchmarks, the clinical signs of organ hypoperfusion are often more critical than any specific numeric value.
What kind of signs are we talking about?
Signs like sudden disorientation or confusion, new onset chest pain suggesting myocardial ischemia, or oliguria, low urine output, suggesting poor kidney perfusion. These signs tell us that vital organs, the brain, the heart, the kidneys, are not being adequately supplied with oxygenated blood regardless of the precise number on the monitor. That's the real emergency.
Mastering PCU care absolutely requires knowing the differential diagnosis for hypotension cold. You have to figure out the underlying cause instantly. The sources break it down into three main categories.
That's right. The first, and by far the most common cause of hypotension in the PCU, is decreased preload, usually due to hypovolemia.
Low circulating volume, why does that happen?
It could be from inadequate fluid or blood replacement during the surgery, ongoing surgical bleeding that wasn't fully recognized or stopped, or critically, something called third space fluid losses.
Okay, third space losses. That's a concept that needs clarifying. It's not simply bleeding out, is it? Can you explain that?
No, it's different from frank hemorrhage. Third spacing refers to fluid shifting out of the functional intravascular space, out of the blood vessels, and into non-functional compartments within the body.
Like where?
Like into the interstitial tissues causing edema, or into potential spaces like the peritoneal cavity, ascites, especially after major abdominal surgery or significant trauma or inflammation. The total body fluid volume might be normal or even high, but the circulating volume, the volume actually contributing to blood pressure and perfusion, drops dramatically.
So what's the first step when you suspect hypovolemia?
The initial treatment is non-negotiable. An immediate intravenous fluid bolus, Typically 300 to 500 milliliters of crystalloid solution, like normal saline or lactated ringers, given rapidly.
And you watch the response. If that fluid bolus fails to stabilize the patient, or the effect is very transient, then the differential diagnosis really opens up, right?
Exactly. If fluids alone don't fix it, you have to strongly consider the other categories. The second major category is pump failure or cardiogenic causes.
Meaning the heart itself isn't pumping effectively.
Right. This could be due to an acute myocardial infarction, MI, happening right there in the PACU, maybe cardiac tamponade restricting the heart's ability to fill, or sometimes negative inotropic or chronotropic effects from anesthetic drugs slowing or weakening the heartbeat.
Okay, so hypovolemia first, then pump failure. What's the third category?
The third category is decreased afterload, which is characterized by pathologically low systemic vascular resistance, or SVR. The pipes are too dilated.
What causes that vasodilation?
It's often caused by the residual vasodilating effects of certain anesthetic agents, particularly volatile inhalation agents, or the sympathetic blockade from high spinal or epidural anesthesia. It can also be due to histamine release triggered by certain medications like morphine or the muscle relaxant atracurium, or in severe cases, it could be the early stages of sepsis.
How do you intervene if you suspect low SVR is the primary problem?
Interventions include ensuring adequate oxygenation, elevating the patient's legs to try and enhance venous return to the heart, performing a careful volume status evaluation, because some vasodilation can be relative hypovolemia, and then, if true low SVR is confirmed, using potent vasoconstrictor medications.
Like?
Typically drugs like phenylephrine, which is a pure alpha agonist, or ephedrine, which has both direct and indirect actions, are used to clamp down on those relaxed peripheral blood vessels and increase the SVR and blood pressure.
Okay, let's shift to the flip side. Hypertension. Defined generally as a rise of more than 20% above the patient's baseline or exceeding age-corrected limits. According to our clinical sources, what is the single leading cause of hypertension in the PACU?
The single leading cause is intense stimulation of the sympathetic nervous system, most commonly triggered by pain. This is often referred to as the somatosympathetic reflex.
So it's the body's natural fight-or-flight response kicking in due to the surgical injury and inadequate pain control.
Precisely. But beyond pain, there are other significant triggers for hypertension in the PACU.
What else should we be looking for?
Respiratory compromise is a huge factor. Both hypoxemia, low oxygen, and hypercarbia, high carbon dioxide, directly stimulate the brain's vasomotor center, causing vasoconstriction and increased blood pressure.
Okay.
Visceral distension is another common one. Think of an acutely distended urinary bladder or bowel sending powerful signals up the spinal cord. And lastly, hypothermia. Being cold dramatically increases circulating catecholamine levels, like adrenaline, and makes blood vessels more sensitive to them, leading to significant hypertension.
So management logically starts with correcting the underlying primary issue.
Absolutely. Give aggressive analgesics if pain is the culprit, correct the respiratory compromise, catheterize the bladder if retention is suspected, warm the patient if they're hypothermic, treat the cause first.
What about patients with pre-existing hypertension?
That needs careful management. Most of their home antihypertensive medications should be continued throughout the perioperative period, although there's some debate around ACE inhibitors and ARBs right before surgery. If hypertension persists despite treating the obvious causes, or if it's severe, then pharmacologic intervention is required.
What drugs are typically used?
Common choices are intravenous labetalol, which offers both alpha and beta blockade, providing vasodilation and heart rate control. Hydralazine, a direct, smooth muscle relaxant causing vasodilation, is another option, as is metoprolol, a beta blocker, particularly if tachycardia is also present.
We also need to briefly acknowledge dysrhythmias or abnormal heart rhythms.
Yes, and the key point here is that these are often transient in the PACU and frequently linked to identifiable reversible factors.
What kind of factors?
Causes range widely. Electrolyte imbalances, especially hypokalemia, low potassium, are notorious triggers. Severe hypercarbia, or hypoxemia, can provoke arrhythmias. Altered acid-base status. Profound hypothermia is known to prolong the heart's refractory period and can lead to sinus bradycardia or sometimes atrial fibrillation.
Other cause?
Sure, things like withdrawal from substances like alcohol or beta blockers or direct effects of drugs used during anesthesia ketamine can cause tachycardia, while some vagatonic drugs or even opioids via respiratory depression leading to hypoxia hypercarbia can cause bradycardia.
Now, here is one of those counterintuitive high-stakes facts that really defines elite practice, something the sources sources highlight.
Go on.
Myocardial ischemia in PACU patients is rarely accompanied by chest pain.
That is absolutely correct and a critical point to internalize. Because of the residual effects of anesthetic agents and potent analgesics like opioids, the patient often cannot perceive or report the typical angina pain associated with myocardial ischemia.
So how do we detect it?
It means we must rely almost entirely on continuous ECG monitoring as our primary surveillance tool. We're looking for subtle changes like ST segment depression or elevation, T-wave inversions, or new onset arrhythmias as our main warning signs. If any suspicion arises based on the monitor or vital signs, a 12-lead ECG must be obtained immediately.
Okay, let's move into the neurologic assessment realm, starting by revisiting that critical, sometimes lurking danger of residual neuromuscular blockade.
Yes, this remains a major source of postoperative morbidity and mortality. Incomplete reversal of muscle relaxants leads directly to increased risk of hypoventilation, upper airway obstruction, and critical aspiration events due to impaired swallowing and cough reflexes.
Mastery here demands more than just a quick look. It requires objective monitoring.
Absolutely. We rely on quantitative monitoring of neuromuscular function, most commonly using a peripheral nerve stimulator to assess the train of 4 TOF ratio. A TOF ratio of less than 0.90 indicates significant residual weakness and impaired respiratory function.
What about those simple bedside tests, like asking the patient to lift their head for 5 seconds or grip your hand?
While those tests sustained head elevation, strong hand grip, ability to bite down firmly or swallow effectively are certainly useful adjuncts, the sources are clear. They are not sensitive enough to reliably detect marginal but still clinically significant residual weakness. A patient might pass those tests but still have a TOF ratio well below 0.9.
And the real danger isn't the patient who is obviously completely paralyzed. That's usually quite apparent.
Exactly.
The danger is the patient who is only marginally reversed, maybe appearing a bit somnolent or lazy breathing.
Precisely. That patient with marginal reversal, maybe a TOF ratio of 0.7 or 0.8, might be overlooked, especially if they are sleepy from anesthesia or opioids. This can lead to insidious hypoventilation developing later, or a catastrophic aspiration event if their protective airway reflexes are subtly impaired.
This is where newer reversal agents have made a difference.
Yes, agents like Sugamidex, which is specifically designed to encapsulate and rapidly inactivate the muscle relaxant rocuronium and vecuronium, have been a significant advance. They provide more reliable and complete reversal, often achieving adequate spontaneous ventilation much earlier compared to the older enzyme inhibitors like neostigmine, which have more variable effects and potential side effects.
Okay, next under neurologic status, let's cover altered mental status, beginning with the sometimes dramatic presentation of emergence delirium, ED.
Yes, ED is characterized as an extreme disturbance of arousal, attention, perception, and orientation, often accompanied by significant psychomotor agitation, restlessness, thrashing, sometimes even pulling at lines or tubes.
It sounds quite common, especially in certain groups.
It's startlingly common, particularly in healthy children, where incidence rates up to 80% have been reported in some studies. Risk factors in kids often include the use of certain volatile anesthetics, particularly sevoflurane. In adults, the use of benzodiazepines preoperatively or intraoperatively has been implicated as a risk factor.
The big challenge for the PACU nurse must be differentiating true ED from simple agitation caused by other underlying issues.
That's the crux of it. You have to rapidly rule out other causes of agitation like unrelieved pain, hypoxemia, hypercarbia, hypoglycemia, or even just bladder distension before labeling it as ED.
Are there specific assessment tools mentioned?
Yes, the sources mention the PSED scale, Pediatric Anesthesia Emergence Delirium Scale, specifically for pediatric patients. For adults, while not specifically validated for ED, the CAM-ICU, Confusion Assessment Method for the ICU, is often adapted and used, sometimes in conjunction with the RAS score, Richmond Agitation Sedation Scale.
How does the RAS score help?
Well, the RAS helps quantify the level of agitation or sedation. Interestingly, if a patient has a RAS score of 0, meaning they appear calm and alert, but their CAM-ICU assessment is positive, it can help flag a hypoactive emergence or delirium, a quiet, non-agitated confusion that can be easily missed but is still significant.
How is ED managed?
Management focuses heavily on prevention, if possible. Things like good preoperative education to reduce anxiety, considering total 4 anesthesia, TIVA, with propofol instead of volatile agents, or using adjuncts like dexmedetomidine, which seems associated with smoother emergence.
And if it occurs despite prevention?
Then, after ruling out those other physiological causes, the priority is patient safety. If severe agitation persists and poses a risk, sedation is required, often using small doses of drugs like midazolam, propofol, or sometimes even ketamine according to specific protocols or algorithms, like the one in Figure 55.2.
Anything specific for children?
Yes, for children, the sources specifically note that simple measures like ensuring parental presence as soon as possible or even playing a recording of the mother's voice have actually been shown to significantly reduce delirium scores. Comfort measures matter.
Okay, then there's the opposite problem, delayed awakening. This is when the patient is simply not waking up as quickly as the clinical team would normally expect based on the anesthetic given.
Right. The clinician thinks they should be awake by now. And the most common reason for this, by far, is prolonged drug action.
Meaning the anesthetic drugs are sticking around longer than expected.
Exactly. This can be due to alterations in pharmacokinetics, how the body absorbs, distributes, metabolizes, and excretes the drug, or pharmacodynamics, how sensitive the patient's body, especially the brain, is to the drug's effects.
What factors influence this?
Many things. Advanced age, underlying liver or kidney disease, slowing metabolism or excretion, profound hypothermia, which slows down all metabolic processes, unexpected drug interactions, or even chronic alcohol or drug use, which can alter receptor sensitivity. For example, significant hypoventilation itself can prolong the elimination of inhaled anesthetic agents because they're primarily cleared through the lungs.
If prolonged drug effect isn't the cause, what's next on the differential?
Metabolic causes are next on the list and must be ruled out promptly. Hypoglycemia, low blood sugar, is particularly common in diabetic patients who have been NPO, nothing by mouth. For surgery, always check a blood sugar.
What about high blood sugar?
Extreme hyperglycemia, often with blood glucose levels over 600 milligdl, can lead to a hyperosmolar non-ketotic state or coma, causing profound lethargy. Electrolyte disturbances are also culprits: severe hypernatremia, low sodium, hypocalcemia, low calcium, or hypermagnesemia, high magnesium, which is sometimes seen in obstetrics patients treated for preeclampsia, can all dramatically delay awakening.
And the rarest but most serious cause?
The rarest but must not miss cause is an acute neurologic injury that occurred perioperatively, things like an ischemic stroke, CVA, an intracerebral hemorrhage, or perhaps uncontrolled extreme hypertension leading to encephalopathy.
So the evaluation follows a logical pathway.
Yes. First, ensure oxygenation and ventilation are adequate. Hypoxia, hypercarbia can cause lethargy. Second, systematically administer specific reversal agents if appropriate. Flumazenil for suspected benzodiazepine overdose, naloxone for suspected opioid overdose, potentially physostigmine for central anticholinergic syndrome if suspected. Third, aggressively identify and correct any metabolic derangements. Give IV glucose for hypoglycemia, calcium for hypocalcemia, etc.
And if none of that works?
If the patient remains unresponsive despite these measures, then you must urgently rule out an acute neurologic cause, typically requiring an urgent CT scan of the head and neurologic consultation.
Finally, under neurologic issues, we need to touch upon a condition that can dangerously mimic other PCU crises, serotonin syndrome.
Yes, this is a potentially fatal condition resulting from excessive serotonin activity in the central nervous system. It's usually caused by the concurrent use of multiple serotonergic medications.
What kind of medications?
Things like MAO inhibitors, SSRIs, selective serotonin reuptake inhibitors, SNRIs, serotonin norepinephrine reuptake inhibitors, tricyclic antidepressants, and importantly for the PCU context, sometimes opioids like fentanyl, meperidine, or tramadol can contribute, especially when combined with other serotonergic drugs.
So basically an overload of the body's happy chemical leading to systemic chaos. What does that look like clinically? How does it present?
It classically presents with a triad of symptoms. First, autonomic hyperactivity, things like diaphoresis, profuse sweating, tachycardia, hypertension, hyperthermia. Second, neuromuscular abnormalities, tremor, clonus, rhythmic muscle contractions, myoclonus, jerking movements, hyperreflexia, and in severe cases, muscle rigidity. And third, profound mental status changes: anxiety, agitation, restlessness, confusion, disorientation.
It sounds like it could overlap with a lot of other critical conditions.
It absolutely can. The differential diagnosis is broad and includes things like malignant hyperthermia, neuroleptic malignant syndrome, anticholinergic toxicity, or even sepsis. The expertise required here is really historical and diagnostic, meaning the clinician must have a precise, up-to-date medication history for the patient, including over-the-counter supplements, and a high index of suspicion when this constellation of symptoms appears, especially if the patient is on multiple relevant drugs. Knowledge of the patient's med list is crucial for making the diagnosis.
And the treatment.
Treatment involves immediate discontinuation of all suspected serotonergic medications, aggressive supportive care, IV fluids, cooling measures, cardiac monitoring, oxygen, and often benzodiazepines to control agitation, tremors, and muscle rigidity. Cyperheptadine, a serotonin antagonist, might be considered in severe cases.
Okay, shifting gears now towards ensuring patient comfort and overall systemic stability as they progress through recovery. Let's discuss pain management. The sources really stress that managing pain effectively is a high priority, not just for the patient's comfort, but for their physiological stability too.
That's absolutely right, because as we just discussed with hypertension, unrelieved severe pain triggers that massive sympathetic nervous system response to the fight or flight cascade, leading potentially to the hypertension, tachycardia, increased myocardial oxygen demand, and even dysrhythmias that can complicate the immediate postoperative period. So the goal is effective pain relief, but with minimal side effects.
How is pain assessed reliably in the PCU?
The gold standard, whenever possible, is the patient's own self-report. We have to ask them using validated tools like simple verbal rating scales, for example, rate your pain from 0 to 10, or the visual analog scale, VAS, where they mark a point on a line. For patients who can't self-report, e.g., nonverbal, cognitively impaired, validated behavioral pain scales must be used, but self-report is always preferred.
The big push in modern postoperative pain management, according to the sources, is the multimodal strategy. What does that entail?
It means moving away from relying solely on IV opioids. Instead, we strategically combine different classes of analgesics that work through different mechanisms to achieve better pain control with fewer side effects, particularly opioid-related side effects.
So what kinds of things are combined?
You typically start with a foundation of non-opioid analgesics like intravenous or oral acetaminophen and NSAIDs like ketorolac or ibuprofen, assuming no contraindications. These are given regularly, awfully scheduled. Then IV opioids like morphine, hydromorphone, or fentanyl are added, but used more judiciously, titrated carefully for breakthrough pain.
Are there other adjuncts?
Yes, other adjuncts might include medications like IV magnesium or low-dose dexmedetomidine infusions, which can potentiate opioid effects and reduce requirements. And increasingly, continuous local anesthetic techniques are used.
Like wound catheters or nerve blocks?
Exactly. Continuous infusion of local anesthetic directly into the surgical wound via a catheter or placement of peripheral nerve catheters, like an interscaling catheter for shoulder surgery or a femoral catheter for knee surgery, that provide targeted, prolonged regional analgesia. These can dramatically reduce the need for systemic opioids.
And here's a mastery-level detail the sources mention regarding opioids. We have to consider genetic factors.
Yes, this is fascinating and increasingly important. Pharmacogenomics plays a role. For example, some individuals have a specific genetic variation. They are poor metabolizers for the enzyme CYP2D6.
What does that mean for pain control?
It means they may get little or no analgesic effect from certain opioids like codeine or tramadol, which require metabolism by CYP2D6 into their active forms. If you give these drugs to a poor metabolizer, they might experience significant side effects but virtually no pain relief, leading to an uncontrolled pain crisis.
So the multimodal approach helps mitigate this kind of personalized variability.
It does, because you're not relying on just one drug or one pathway. It provides a more robust and reliable analgesic foundation for more patients.
When opioids are needed systemically, what about patient-controlled analgesia, or PCA?
PCA, whether intravenous or epidural, is an excellent tool for maintaining pain control once the initial severe acute pain has been brought under control in the PACU. It shouldn't usually be started until the patient is relatively comfortable and able to understand how to use the device.
On the flip side of opioids, we have to manage their side effects. The sources highlight bowel dysfunction, or postoperative ileus, as a major issue.
It is. Opioids significantly slow gut motility. For patients, especially after abdominal surgery or those requiring prolonged opioid use, managing this is crucial. The development of peripherally acting mu-opiate receptor antagonists, PAMORAs, has been a big help here.
How do those work?
Drugs like alvamopin, oral, methylnaltrexone, injectable, or naloxegol, oral, selectively block the opioid receptors in the gut wall without crossing the blood-brain barrier significantly. So they counteract the constipating effects locally in the gut without reversing the central analgesic effects of the opioids. Pretty clever.
Okay, let's move to another common PACU issue. The insidious threat of hypothermia. This is defined as a core body temperature below 36 degrees Celsius or 96.8 degrees Fahrenheit. And the sources are clear. This isn't just about patient discomfort.
Not at all. Hypothermia is a major driver of prolonged recovery times and is associated with significantly increased patient morbidity.
In what ways?
Specifically, hypothermia impairs coagulation, increasing bleeding risk. It impairs immune function, increasing the risk of surgical site infections. And critically, as the body tries to rewarm, it dramatically increases metabolic rate and oxygen demand, which can strain a compromised cardiovascular system.
We need to understand how patients lose heat in the perioperative environment. The sources break it down into 4 primary physical mechanisms.
Right. The largest contributor is usually radiation, accounting for maybe 40% to 60% of heat loss. This is just the passive loss of infrared heat energy from exposed skin surfaces to the cooler surrounding environment, like the OR walls.
Okay, what's next?
Next is convection, responsible for perhaps 25% to 50%. This is heat loss due to air currents moving across the skin, like the airflow from ventilation systems in the OR. Wet skin exacerbates this.
And then evaporation.
Yes, evaporation can account for up to 25% of loss. This comes from moisture evaporating from exposed surgical incision sites, mucous membranes, and water vapor in the patient's exhaled breath.
And the last one.
And finally, conduction, which is usually a smaller component, maybe up to 10%. This is direct heat transfer through physical contact with colder objects, like an unwarmed operating room table or cold 5E fluids.
Who is most at risk for developing hypothermia?
Risk factors include the extremes of age. Neonates and the elderly have less effective thermoregulation. Female gender, patients who are intoxicated, those on certain medications. But most notably, both general and major regional anesthesia, like spinal or epidural, are major culprits.
How do anesthetics cause heat loss?
They do 2 main things. They depress the central thermoregulatory center in the hypothalamus, reducing the body's ability to sense and respond to cold. And they cause peripheral vasodilation, which allows core body heat to redistribute rapidly out to the cooler peripheral tissues and skin, causing a significant drop in core temperature, especially in the first hour of anesthesia.
And physiologically, hypothermia causes that dangerous left shift in the oxyhemoglobin dissociation curve we mentioned earlier.
Yes, meaning hemoglobin holds onto oxygen more tightly, impairing oxygen release and availability to the tissues precisely when metabolic demand might be increasing due to cold stress.
And then there's the visible effect, shivering.
Right. Shivering is the body's involuntary rapid muscle tremor. It's a frantic physiological attempt to generate heat, but it comes at a huge metabolic cost. Shivering can dangerously increase the body's overall metabolic oxygen demand by as much as 400% to 500% above baseline.
That's a massive increase.
It's huge. And in a patient with already compromised cardiac or respiratory function, that sudden massive oxygen demand can precipitate ischemia or respiratory failure.
So management really focuses on prevention in the OR, but once a patient arrives cold in the PACU, what's the priority?
Once in the PACU, active warming measures must be instituted promptly. While passive measures like cotton blankets help reduce further locks, active warming is needed to raise the core temperature.
What's considered most effective?
The sources consistently highlight forced air warming blankets as the most effective method for actively transferring heat to the patient and achieving rapid rewarming, significantly reducing the time required for the patient to reach normothermia, a normal temperature. Treating shivering might involve small doses of opioids like meperidine, in addition to aggressive rewarming.
All right, let's discuss another very common and distressing issue. Postoperative nausea and vomiting, or PONV. While generally not life-threatening, PONV affects a huge number of surgical patients.
It really does. The baseline incidence is estimated at 20% to 30% of all surgical patients, but that number can skyrocket to 70% or even 80% in certain high-risk individuals.
And it's a major factor in patient dissatisfaction.
Huge factor in dissatisfaction, and it remains one of the primary reasons for prolonged PACU stays, delayed discharge, and even unanticipated hospital admissions after ambulatory surgery. It significantly compromises quality of recovery.
The risk factors for PONV are quite specific and well-defined, often quantified using scoring systems like the APFL or Quadrant scores. What are the key independent predictors we absolutely must know?
There are several strong predictors. Female gender is a big one. Women have a 2 to 3 times higher risk than men. Non-smoker status is another. Interestingly, smoking seems to offer some protection against PONV.
Strange. What else?
A prior history of POV after previous surgeries or a history of motion sickness are both very strong predictors. From the anesthetic side, the use of volatile inhalation anesthetics is a major risk factor compared to IV anesthesia like propofol. And postoperatively, the use of opioids for pain control significantly increases PONV risk.
Does surgery duration matter?
Yes, longer surgical duration, typically defined as lasting 60 minutes or more, is also an independent risk factor. The more risk factors a patient has, the higher their likelihood of experiencing PONV.
Given how common and impactful PONV is, the management strategy really has to be proactive, doesn't it?
Absolutely. The mantra is, prophylaxis is strongly preferred over rescue treatment. It's much easier and more effective to prevent PONV than to treat it once it starts.
How do we do that prophylactically?
Well, first, employ those multimodal analgesic strategies we talked about to minimize opioid use. Consider using regional anesthesia techniques whenever appropriate. If general anesthesia is needed, favoring a total intravenous anesthesia TIVA technique, usually based on propofol, which has antiemetic properties, over volatile agents can significantly reduce risk. And ensuring adequate intravenous hydration is also important.
And then there's pharmacologic prophylaxis, giving antiemetic drugs preventatively.
Yes. And the strategy here is typically tiered based on the number of established risk factors the patient possesses.
How does that work?
Generally, a patient with 1 or 2 risk factors should receive prophylaxis with probably 2 different antiemetic agents. A patient with 3 or more risk factors is considered high risk and should receive combination therapy with 3 or even 4 different agents.
And critically, these agents must be selected from different pharmacological classes, right, to target different pathways.
Exactly. That's the key to multimodal prophylaxis. For mastery, you need to know the different classes. You might combine a 5-HT3 receptor antagonist, like ondansetron or granisetron, which blocks serotonin receptors in the gut and brainstem, with an NK1 receptor antagonist, like aprepitant or rolapitant, which blocks substance P receptors involved in vomiting reflexes, and perhaps also a corticosteroid, like dexamethasone, which has anti-inflammatory and antiemetic effects, though the mechanism isn't fully clear.
Other classes.
Other useful classes include dopamine antagonists like droperidol or the newer amisulpride, antihistamines like dimenhydrinate, and anticholinergics like transdermal scopolamine patches applied preoperatively. The idea is to hit the problem from multiple angles.
What happens if PONV occurs despite good prophylaxis? What's the rescue strategy?
If rescue treatment is needed, the crucial rule is to use an antiemetic from a different pharmacological class than the agents the patient already received prophylactically. Using another drug from the same class is unlikely to be effective.
Are there any non-pharmacologic interventions that help?
Yes, and some have decent evidence. Acupuncture or acupressure at the P6 acupoint on the wrist has been shown to be effective. Simple aromatherapy, particularly inhaling the vapor from an isopropyl alcohol swab or using peppermint oil, can provide rapid, albeit temporary, relief for some patients. Controlled deep breathing techniques can also help manage nausea.
Okay, let's wrap up this section with fluid management and urinary output. Modern perioperative care principles, especially those guided by ERS, Enhanced Recovery After Surgery, pathways, really emphasize goal-directed fluid therapy, or GDFT. What's the main goal there?
The primary principle behind GDFT, particularly in major surgery or high-risk patients, is really to prevent excessive fluid administration and avoid fluid overload. We now recognize that overly generous fluid resuscitation can increase cardiopulmonary complications, impair gut function, and prolong recovery. So the goal is euvolemia maintaining adequate intravascular volume and tissue oxygen delivery without causing harm from excess fluid.
How do we assess fluid status in the PTU?
We look for clinical signs of hypovolemia, like poor skin perfusion, cool, clammy skin, slow capillary refill, hypotension, and tachycardia. Invasive monitoring like central venous pressure, CVP, or pulmonary artery pressure monitoring might be used in complex cases. Urine output is monitored closely, but it needs careful interpretation.
Why is urine output potentially misleading?
Because oliguria, low urine output, often defined as less than 0.5 milliliters per kilogram per hour, in the early postoperative phase can sometimes be an appropriate physiological response to surgical stress and hormonal changes, like increased ADH secretion, or it might reflect transient renal impairment due to anesthetic effects or renal hypoperfusion during surgery. It doesn't always mean the patient needs more fluid immediately. Conversely, osmotic diuresis from hyperglycemia can mask underlying hypovolemia.
We also need to actively monitor for postoperative urine retention, or PORR. What increases the risk for that?
Risk for POR is significantly increased by regional anesthetics, especially spinal or epidural blockade affecting bladder nerves, systemic opioids, certain drugs like ketamine, and even NSAIDs. Underlying conditions like diabetes or BPH also contribute.
How is POR assessed?
The standard practice now for non-invasive assessment is using a portable bladder scanner to measure the post-void residual volume. If significant retention is found, intermittent or indwelling catheterization may be needed.
Can patients be discharged home if they haven't voided?
This is a critical point. For selected, low-risk ambulatory surgery patients, discharge without voiding may sometimes be considered acceptable according to specific facility protocols, but only if they are provided with extremely clear, detailed follow-up instructions on when and how to seek help if they are unable to void later, along with criteria for concern. It requires careful patient selection and education. For inpatients, it's generally managed before they leave the PCU area.
And what about oliguria itself? When does it become a major concern?
Oliguria always warrants attention, but it needs particularly aggressive evaluation and management if the patient has other risk factors for acute kidney injury, such as prolonged hypotension, massive transfusion during surgery, sepsis, or procedures involving aortic cross-clamping.
What about polyuria, excessive urine output?
Polyuria in the PACU usually reflects generous intraoperative fluid administration or perhaps ongoing osmotic diuresis from hyperglycemia that needs correction. However, sustained, very high urine output, for example 4 or 5 millikcal/kR or more, despite adequate hydration might raise concern for abnormal renal water clearance, such as diabetes insipidus, especially after neurosurgery. ### discharge from PACU phase 1.
Okay, we've synthesized the assessment, the potential crises, the management strategies. Now let's talk about the final hurdle in this initial intense recovery phase. The criteria for safe discharge from the phase I PACU, moving either to a less monitored setting, phase 2, or to an inpatient ward.
Right, and the prerequisites for safely leaving that high-intensity phase I environment are quite comprehensive. The patient really needs to demonstrate substantial recovery.
What are the key benchmarks?
They must be sufficiently oriented to person, place, and time, or at least back to their preoperative baseline, and importantly, be able to summon assistance if needed. They need to possess adequate protective airway reflexes, like coughing and swallowing, and demonstrate sufficient motor function, especially after regional anesthesia or if residual muscle relaxant was a concern.
What about respiratory and cardiovascular stability?
Absolutely crucial. They need to maintain acceptable ventilation and oxygenation after any supplemental oxygen has been discontinued for a defined period to ensure they're stable on room air. Hemodynamics, heart rate, and blood pressure must be stable and consistent, generally within 20% of their baseline values.
Other factors.
Yes, they must be reasonably normothermic. The sources often cite a target temperature of at least 36.0 degrees C or 96.8 degrees Fahrenheit. Any significant shivering should be resolved because of that high oxygen consumption. And finally, pain and nausea vomiting must be effectively controlled with oral medications or interventions manageable in the next care setting.
This is where those scoring systems we mentioned earlier, like Aldrete, come back into play for decision-making.
Yes, scoring systems regain their utility here as objective tools to help standardize the discharge assessment. The modified Aldrete post-anesthetic recovery, PAR score, is commonly used for assessing readiness for phase I discharge. The modification typically involved changing the assessment of skin color to the more objective measure of oxygen saturation.
And for patients going home directly from recovery, or after phase 2.
For outpatients, specific discharge scoring systems focused on street fitness are often utilized. The PADS, the Postanesthesia Discharge Scoring System, is a well-known example. It's a simple, objective tool that adds criteria specifically relevant to home readiness.
What does the PDS include?
It typically assesses vital signs stability, activity level, gait ambulation, nausea vomiting control, pain control, and sometimes surgical bleeding or voiding status. A minimum score, often 9 out of 10, is usually required before an outpatient is considered ready for discharge home. Another system mentioned is the modified PR score for outpatients, Table 55.6, which includes criteria for dressing status, pain, ambulation, fasting feeding tolerance, and urine output.
Now, there's also the concept of fast tracking mentioned in the sources. What is that?
Fast tracking refers to the practice of transferring select, very low-risk patients directly from the operating room to the less intensive phase 2 recovery area, completely bypassing the traditional phase I PICU.
What's the motivation for that?
It's primarily driven by potential cost savings and improved efficiency or patient flow. However, the sources strongly emphasize that the criteria for selecting patients eligible for fast tracking must be extremely strict and reliable.
Why the caution?
Because you are inherently skipping that period of intense one-on-one monitoring and assessment that occurs in Phase I. There's a risk of missing subtle deterioration if the patient selection criteria aren't rigorously validated and applied.
And for all outpatients, regardless of whether they went through Phase I or were fast-tracked, there's a final rigid requirement for discharge home.
Absolutely non-negotiable. They must be discharged into the care of a responsible adult who will accompany them home and ideally stay with them for a period. They cannot leave alone, especially after sedation or anesthesia.
And they need instructions.
Yes, they must leave with clear, comprehensive, written post-procedure instructions covering things like diet progression, medication schedules, especially pain meds, activity restrictions, wound care, and critically, very specific instructions on signs and symptoms that should prompt them to seek immediate medical attention or contact emergency services. Hashtag outro.
We've covered a huge amount of ground today, from the mechanics of laryngospasm and negative pressure pulmonary edema to the nuances of multimodal pain control and the interpretation of discharge scores. What is the overarching synthesis? What truly defines mastery of this demanding PCU environment?
I think mastery requires that seamless integration of profound physiological understanding, really knowing why hypokalemia inhibits neuromuscular reversal or why non-cardiogenic pulmonary edema happens after obstruction with rigid procedural adherence.
Adherence to things like
the standardized handoff protocols, the evidence-based tiered PONV prophylaxis strategies, and the accurate use and interpretation of objective monitoring tools like capnography for ventilation and the PADS for discharge readiness.
So it's knowledge plus process.
Exactly. And the unified goals behind all of this are maximizing post-anesthetic patient safety, improving the quality of their immediate recovery experience, and demonstrably reducing the incidence of predictable adverse events through vigilance and timely intervention.
That balance seems absolutely crucial. And the source material itself offers a caveat here, noting that despite all these useful scoring systems and protocols, fixed PACU discharge criteria must always be used with caution. Why? Because the variability among individual patients is tremendous.
That's right. Two patients might have the same PACU score, but their underlying clinical trajectories could be quite different based on factors not captured by the score.
And this leads us perfectly into our final thought for you, the listener, to consider. The truly elite professional working in the PACU must expertly strike this delicate balance. The balance between relying on objective data, the scores, the vital signs trends, the lab results, and trusting their subjective, experienced clinical judgment, that gut feeling, often developed over years of practice in this rapid-fire, high-stakes environment.
It's a constant tension.
So the provocative question is, how does the seasoned practitioner reconcile a situation where perhaps the patient meets all the objective discharge criteria, maybe gets that passing KD score, but something in their clinical intuition, their overall assessment, still signals that something isn't quite right, that this patient isn't truly ready or safe for the next step?
That continuous synthesis of objective data and subjective clinical wisdom, knowing when to trust the numbers and when to trust your gut based on the whole picture, that is perhaps the true hallmark of mastery in the PACU.
That critical distinction data versus clinical wisdom and the art of combining them is the crucial lesson we take from this deep dive into the Postanesthesia Care Unit. Thank you for joining us.